it's your weight adjusted for your height, and definitions for the BMI have been, underweight, normal weight, overweight, and obese. Class 1, 2 and 3 obese for many years, and strangely enough, the cut point at 30 has been the cut point for obesity, a diagnosis of obesity in European people. It doesn't alter for other ethnicities. So what's happened is that we're saying, well, that doesn't tell us anything about the fatness. We do know BMI is a reasonably good measure of fatness, but it doesn't tell us anything about where you store your fat. It doesn't tell us anything about how sick you are, or whether you have no issues with health or a lot of issues with health. So we've had this dilemma as to some people talking about obesity as always a disease, and many organisations around the world do believe that. On the other hand, many accepting that it's not a disease, it's a risk factor only and a lifestyle problem. So we've got this controversial thing, and this process for defining it more clearly, that's clinical obesity more clearly, has gone on for nearly 5 years. And 57 people from experts from around the world have got together, and it's been a really quite clear process. What we've come up with is that people who are obese do need to have excess fat, and we need more than a BMI to confirm that. We need to look at the waist-hip ratio, or weight-height ratio, or even in some cases looked at a DEXA, which can measure the amount of fat in the body. The problem is that if we have some perfectly fit, healthy athletes that are a BMI over 30, and on the other hand we have people who are sick with a lot of the complications related to obesity at a level which is in the high overweight range. So, John, we want to define this.
So these changes would affect the diagnosis and care of patients?
Yes, the idea really is to sort of accept that when is obesity a disease? When is it causing problems? And when is it an illness? Is it interfering with the organs of the body? Is it a progressive process? Because in a lot of people, it's exactly what it is. So we've defined obesity as excess fat, and a clinical obesity as excess fat with established conditions that are due to the obesity. For instance, arthritis of the knee, or breathlessness due to the lung volumes being changed. We have people who have developed heart disease as a result of a combination of metabolic, inflammatory and hormonal disturbance. And we look at all those factors and say, well, if they've got those, they've got a disease and we need to treat.
Okay, but conversely, there will be some people whose BMI will be over 30, but who you described are athletes. They're not unwell, but nevertheless are being treated and are receiving treatment for obesity.
No, they're not. Well, at the moment, they could be. They could be classified as obese, even though it's muscle. So that's a very small group of our community, but it's real.
Okay.
And on the other hand, we've got that group that aren't at that level, but do have a lot of obesity-related complications in the overweight range.
So how have these proposals been received overseas, John? And is there any resistance to changes being made here in Australia?
Well, importantly, there's 70 or more major international associations have already endorsed these, and including our Obesity Society here in Australia and the Bariatric Surgical Society here in Australia. It's been endorsed by major authorities, and when we think about it, the whole world has been represented in putting this together. It's not just one country, and it's gone on for a long time. There's been debates and so forth. So what we're really now doing is saying, well, those organisations have had a look at it. Now we want the world to have a look at it, and I think they'll find it very positive in the sense that GPs, and they're the people on the ground, they will understand that now they've got a clear marker for those who need care. In the past, we've just blamed and shamed people who've got obesity, stigma's been widely there, and there's no responsibility for someone to actually take that treatment step. So people with clinical obesity should be assessed properly by their doctor for the characteristics that the signs, the symptoms, and the tests that show it, just as we would any other chronic disease. And then, if they've got a diagnosis of clinical obesity, then they need to be given the options for care. It's not saying they have to have care, but we would like to make sure that they've got the options and at least that they're reviewed and looked after.